Hi, my name is Jason E. Lake. I'm an orthopedic surgeon specializing in foot and ankle, and I'm going to take a few minutes to talk about osteomyelitis. Um, what is osteomyelitis? Well, osteomyelitis is essentially a bone infection. These are typically infection is from bacterial. It would be very, very rare or unheard of to have a viral bone infection, but once in a while, a fungus can pop up in a bone as well. How does osteomyelitis occur? Well, there's different ways that a bone can get infected. The bone can get infected through the bloodstream, which is hematogenous spread, and in this case, it may come from another body part where there is an infection. And this is more common in children as opposed to adults, but is possible in adults. Additionally, patients can have exposed bone, and exposed bone can be from a traumatic injury, such as an open fracture or a puncture, or a lot of times in the hospital setting, it'll be from a chronic wound or an ulcer. And a lot of times this will present in our sicker patients with diabetes, peripheral neuropathy, or vascular disease. And the last place that we'll see a bone infection can be post-operative. So sometimes from an orthopedic procedure where there is an operation on or around bone, the patient can develop an infection deep into the bone as a result of the operation. Who gets osteomyelitis? Well, what are the symptoms of osteomyelitis? Well, swelling, warmth, redness, fevers or chills. Sometimes patients will have fatigue or feel tired. Some diabetic patients with peripheral neuropathy may actually not think their symptoms are too bad because they don't have a lot of the pain or the other things that are associated with it. And so they can present and for another medical problem, and sometimes the ulcer or the bone infection will get picked up by the medical team when they're in the hospital. How is osteomyelitis diagnosed? Well, there's several different ways. Clinical exam, if there's a wound and you can probe the bone with a sterile Q-tip or a device, then typically there is a bone infection present. Not every time, but most of the time. Lab work, patients will have an elevated white count, SED rate, or CRP, but these can be elevated from other things in addition to osteomyelitis. Sometimes patients with really chronic low-grade osteomyelitis will have normal blood work. X-rays can be helpful if the osteomyelitis has been present at least for a week or two or longer. Erosive changes will start, but the first couple days you may have a fairly normal X-ray. And here's an example of an X-ray where the fifth metatarsal head is being eroded from the infection. You can compare that to the other metatarsal heads, and it looks like it's disappearing essentially. A CAT scan can pick up similar findings as the X-ray. It's a little bit more sensitive than an X-ray, but it's not as sensitive as an MRI. Other diagnostic tools, an MRI is excellent for early osteomyelitis. It will pick up the bone marrow edema before the bone starts to erode, so an MRI can be very helpful. In the hospital, these are usually ordered with and without contrast unless the patient has renal or kidney issues. The other thing about an MRI is it doesn't guarantee our diagnosis. It's very sensitive, so it will capture most of the osteomyelitis, but it's not as specific. So that means that there are other conditions which may show marrow edema patterns similar to osteomyelitis that are not osteomyelitis. So MRI, very, very helpful, but not definitive for the diagnosis. Bone scans can be helpful. A traditional bone scan will light up hot over an area of increased bone marrow turnover, such as when there's a bone infection. But sometimes other conditions, again, can cause a positive bone scan. When you take a traditional bone scan and you add to it a sulfur colloid scan, this can be very helpful in starting to pinpoint osteomyelitis versus other chronic conditions of the bone, such as when a fracture is present or fracture is not healing appropriately, the bone scan may be positive, but with a sulfur colloid scan, you can help differentiate between another chronic bone condition and osteomyelitis. How else is it diagnosed? Well, when in doubt, you get a bone biopsy. So if there's the MRI or the bone scan or the X-ray combined with the physical exam and the blood work, if the picture is not matching up and you're still wondering if the patient actually has osteomyelitis, then you can always get a biopsy and send it to the pathologist and rule it out or rule it in. How's osteomyelitis treated? Well, number one, we have to make sure that there's good flow to the area. All of the treatments, whether it is surgery or antibiotics, require that portion of the bone to have good blood flow. So we always check the patient's pulses. Often we'll get a vascular consult to make sure that the area is well perfused. Additionally, you need to have good deep cultures to confirm the organism that's actually causing the infection. Typically, there's an aggressive surgical debridement. Depending on the location, as well as the patient's overall health status, sometimes scraping bone and debriding it is not enough. Sometimes an amputation is the preferred method. For example, a toe, if you're going to remove a significant section of the bone in the toe, sometimes it's better to just remove the toe in its entirety. Another example would be the heel bone. You can't really remove the heel bone and expect the patient to have the ability to walk. So if a patient's really sick and has diabetes and vascular disease, and they have a significant infection in their heel bone, it may not be able to be saved. In addition, if there is just a debridement and an amputation is not performed, and you still have tissue around where the infection was, then sometimes an antibiotic cement will be placed, and the antibiotic cement has antibiotic powder in it, and it will reach a level of antibiotics that's higher than just the IV antibiotics alone. In addition to the surgery, typically IV antibiotics is used for 6 or 8 weeks, and this is based on what the culture shows. Now, if there's an amputation that's performed and you've removed all the area of infection and you have a very clean margin, then long-term antibiotics may not be required. But if you're trying to save the foot, then IV antibiotics, with or without antibiotic beads or bone cement, are required. Occasionally, long-term suppression in a high-risk surgical patient with antibiotics can be performed, or if it's an area that's very difficult to access, sometimes a trial of antibiotics alone will be performed. Or if someone has a really chronic low-grade infection, sometimes these can be watched, and if it never turns into an acute flare-up or cellulitis with the osteomyelitis, some patients with a small area of chronic low-grade bone infection can be treated with suppressive antibiotics, but overall this is pretty rare. The prognosis overall is pretty good as far as patient living through it, getting through it, but in patients with diabetes and vascular disease, it can lead to loss of toes, portion of the foot, or all of the foot. Some patients will develop scar tissue. Some patients will get recurrence based on their ability to heal their surgical wounds, as well as their comorbidities and whether or not they're compliant. Additionally, if bone is removed or portions of a limb are removed, it does change weight bearing, so custom orthotics or braces may be required to account for the changes in the structure of the foot. That's about it. If you have any questions, please feel free to contact me, but there's a high-level summary of osteomyelitis.